I wanted to start with you, Mr. Williams. The indicator that we hear all the time here in Texas when we talk about health is the high percentage of people that are uninsured, right? It's 17%, if I'm not wrong. The following state is 4 points below, which is Oklahoma, I think. And then if we look at Hispanics, it goes much larger, 27%. And if we look at the big cities that we have in the States, it's probably something bigger than that 70%, right? So I assume that a lot of the burden of this issue falls in cities and departments of health like yours, right? How does it look in Houston in particular? What are the actual practical consequences of this high number?
Well, first of all, those numbers that you quoted are low. Actually, the uninsured rate is much higher in Houston, and amongst Hispanics, it's much higher than you quoted. One thing I want to distinguish is the difference between public health and healthcare itself. And when you're talking about people that are uninsured, you're talking about health care. You're talking about what one would do for an individual. In the health department, we're actually responsible for protecting the health of the population, for promoting the health of the population, for actually ensuring that as a city, Houston is prepared for man-made or natural disasters. Access to health is an important issue from a public health standpoint. We see our role as being one of linking people to healthcare. As a matter of fact, doing ACA enrollment, we created a coalition of interest, both private, public sector, nonprofit, called Enroll Gulf Coast. We were successful in that effort, and that effort is still ongoing. As a matter of fact, 2 days ago, that group led an effort, I think it was at Telemundo, to help folks get enrolled and to be assisters. But really, in order for people to have adequate health, I think access to care is just one key component. There's a lot of things that should happen after that, but I think access to care is just basic to that.
And we're going to talk about that and the way that many organizations, not only the department, but organizations like yours, Elena, get creative to work on these issues. But before that, I wanted to touch a little bit more the political part of this conversation. Representative, cities, health providers, nonprofits are trying to solve this kind of issues, but we have a leadership in the legislature that actually has, we hear them saying that they are trying to make things difficult for cities sometimes. How does healthcare, and this issue in particular, relate to these tensions, and is there any way of bridging these tensions for improving the healthcare and the healthcare in the state, and the way that the state government can help cities providing better healthcare and improving the healthcare levels here in cities like Houston?
We do a lot in the legislature to help not only urban areas but also rural areas as well. We are cognizant of the fact that we have a responsibility in the area of healthcare. And that's the reason why we fight so hard to make sure that we work hard to get the 1115 waivers in, because they're very important, very significant. We are concerned not only about health care, mental health care, early childhood, all aspects of care, as well as nutrition that is coupled with that, which is a big component of that particular aspect. It is not a fact of that we don't care about health care. We do care about it. And that's the reason why each session of the legislature, we strive very hard to make giant improvements where we can in those particular areas. A lot of people are not familiar with a lot of the urban areas, but since the legislature has becoming more urbanized, people are beginning to see the big picture of what healthcare really encompasses. And I think that has been a plus. The disaster has taught us a lot. Harvey, Imelda, some of the past hurricanes and things, and they have brought challenges to our community. And those challenges in the area of healthcare has caused us to be more proactive in being able to try to address those particular issues.
And in the case of Harvey in particular, we saw both sides of the aisle coming together, finding solutions. Are there any lessons that we can take from that experience that we could apply into healthcare legislation too?
I think so, absolutely, absolutely, because Harvey brought some new issues, and it kind of compounds some of the old one. For example, we recognize that when children are impacted by hurricanes and they go to school, they have problems with stress because of the impact of what has happened to them, and making teachers more cognitive of that kid as not being an undisciplined kid or a kid that's being difficult just to give the teacher a hard time or classmates a hard time, but that kid is suffering from some kind of trauma that they have encountered. So we are cognitive of those particular things, and we're trying to to address those particular issues and not send a kid, to detention, but to be able to get some kind of services for them to help them to overcome those issues.
Elena, from the nonprofit world, you're in touch with all these actors in the healthcare sector and in health-related issues. Do you experience or do you see also these tensions impacting your work and the work of the institutions that you work with?
What I would say is that we ought to be talking about health and not healthcare. Healthcare is one piece of the puzzle that ensures that a person, a family, a community is healthy, but it's just one piece. And we in this country are obsessed with healthcare, and we put all of our thoughts and, most importantly, all of our dollars into healthcare. And I share Stephen's perspective that if we really want to improve the health of populations, we have to look at something outside of healthcare. I approach it a little bit differently in that I spend a lot of time in the healthcare sector, and the reason I do that is that's where the money is and that's where the attention is. And if we're going to be able to fund a healthier population, it's going to have to come through the healthcare sector because that's where the money is, and there's not another pot of money. And so what I would propose that we do is when we're talking about health care, that we talk about it in terms of its contribution to health outcomes, and that we either stop using the term health care and use the term health, or we broaden the definition of care so that it includes all sorts of other things that people actually need more so than health care or medical services to be healthy.
Can you tell us a little bit of how does that difference look like on the ground? Like what's the difference when you mention health and not just healthcare? What does that look like for you, for example, and why is that so important?
So here's an example going on in Harris County today of what it looks like to us. We work with a clinic in Northwest Harris County that sees a lot of low-income and uninsured and Medicaid and CHIP kids. And they noticed that a lot of their kids have asthma, and that even though they're insured and the asthma is medically controlled, they've got the medicines they need, they are still winding up in the ER and in the hospital repeatedly. And what they started doing was visiting the homes of these kids, and they learned that a lot of them have conditions in their households that are triggering their asthma attacks. And what they started doing was saying, well, let's fix the homes. Let's get rid of the mold. Let's change out carpets. Let's talk to the families about what they can do within their house to make it a safer environment. And that's actually improving the health outcome. But the way our current insurance system is structured, it won't pay for that. And so I'm working within the health care sector, including the insurance plans and the state Medicaid agency, to help them recognize that they can fix this apartment and actually, for less dollars than what it costs to go to the emergency room one time, actually improve health outcomes and reduce health care costs. So that's an on-the-ground example, and there are many more. And we need to incorporate that kind of thinking and that kind of care into the health care financing system.
Dr. Sharma, your line of expertise is food insecurity, and that's a huge issue here in Texas. And it's precisely, I guess, one of the areas when we can see this difference between health and healthcare. Can you explain how does that look here in your work here in Houston? How do those two factors combine, and how you can get like great outcomes by focusing on health?
Yeah, I mean, honestly, these are all related, right? They coexist within the same individual and the family. So a family who's struggling with food insecurity is also struggling with access to care and health care, right? So, so we have to understand that if you think about this health iceberg framework, what you see on the top, what's visual are the health outcomes that the patients show up with on the ER or in their clinic. But the iceberg, if you look just under the surface, you have all of these social determinants of health or social drivers of health, whatever you want to call them, including food insecurity.
What are social determinants of health? Because that's a concept that I heard from all of you when I was preparing this.
Yeah, I mean, in really, simple terms, it's all the factors that influence the way you live, the way you eat, the way you play. So it's, it's food. It's, if you think about the Maslow's hierarchy of needs, it's things at the very bottom, your food, your shelter, your access to care. All of those factors are considered social determinants of health. So they're not wants. I think that's an important distinction, that these are basic needs of the families that need to be met to live, right? So they're not necessarily something that's more than what their human rights are.
And it's interesting because when we talk about cities, we are talking about this, I guess cities have an approach that it's much more holistic a lot of times to problems. And you were mentioning too that these social determinants of health were really important for the department here. Can you tell us how the department is working in all of this wide range of areas?
I'm trying to figure out which program I really want to talk about, to be honest with you. I'll use an example where we actually contracted, and it's really close to everybody because we're downtown in Houston. If you step out and start looking under the underpasses, you'll see a number of homeless individuals. One of the projects that we have, actually it was funded by our 1115 waiver, is where our department contracted with healthcare from the homeless and HACS, which is an FQHC, to provide services to individuals who were chronically homeless. The primary thing that people needed, the old thinking was you get people prepared to go in the houses. Now with Housing First, we were able to partner with the housing department to provide units for the people who are chronically homeless. And so there was a place for folks to access. The clients, with Healthcare for the Homeless, they were able to actually go to the units where people were chronically homeless and provide what we would term as wraparound services, both primary care, behavioral services, and provide for folks' basic needs. That has actually resulted in this part of that project in keeping close to 150 people off of the streets that would have been on the streets, because we were able to be comprehensive in our approach and not just look at access to care, which would be seeing the doctor.
Mm-hmm. And homelessness is such a good example of what we're talking, right? We can't solve homelessness without thinking about health. We can't solve homelessness without thinking, of course, about housing, about jobs and job opportunities.
And
but
it's mental and physical
and
health.
mental health too.
Mental health is a huge component.
Food insecurities for sure, another topic there. Yet when we hear of the political conversation, for example, on homelessness, we see it in a very siloed way sometimes. And we've seen what has happened with the controversy in Austin. That seems to be sometimes an issue of policing and of security rather than anything else, and the other factors sometimes are forgotten sometimes. Representative, do you think in Austin things are moving, and in the Ledge things are moving towards this more holistic kind of perspective, or we still have the silos of healthcare here, housing here, and so on?
We'll look at it from a holistic point, and let me give you an example. About 2 sessions ago, I passed some legislation that allowed the universities to study post-traumatic stress disorder, and from a holistic approach, integrated approach, because you can't just treat one thing without looking at the whole scheme of things that really impact persons. And this was geared toward veterans. And this past session, I tried to move about a $6 billion bill to study the brain. And I wanted to study the brain because of the fact that I want to find out what are the things that are triggering, what are those triggers that are causing many of the problems that we're having, not only in children, particularly in children. Because when you start looking at a kid 7 years old who tries 3 times to commit suicide and succeeds on the 3rd time, you try to, at 7, you wonder, and why is a kid at 7 being treated for depression? What is it in that brain? And it took me back some years when I taught school, and I had kids wouldn't sit down to save their lives. And how many times I tell them, sit down, sit down, sit down. They were popping up. But 20 years later, we heard about ADD and ADHD. What are those other triggers out there that we don't know about, that we can find out about and develop protocols? But more importantly, we can be able to find cures for. And wouldn't it be something wonderful to find a cure of dementia?
But how easy is it actually to pass these kind of bills?
Well, let me tell you about it. I got it as far as to the Senate. It got on the top of the Senate calendar, and the lieutenant governor did not see fit to call the next bill up. It was the next bill on the calendar to be considered the last day. But guess what? Going back next session.
Another issue that I hope that we see more in next session, and I know that it's one that it's very close to your heart, and it's related to what you were talking, is the issue of mental health. And we've heard the governor talking a lot about mental health after the shootings that we've seen in the state. Are you more optimistic also that we might see more conversation and actual success in passing legislature?
I am, because you know what I know? You can put up all of the fences, metal detectors, and all the things that you want in school, and bulletproof glass. But until you find out the cause, it's not going to work. And we want to find out, what is it? Why? And we've done a lot of things in this state, because we have done a lot of things to enhance mental health in children, particularly in schools. And we have put more psychologists and master's degree social workers in schools to be able to give those kind of services there. But not looking at it in a silo, because we recognize you can help the child, but if you don't help the family, then maybe problems exist, or maybe the whole family may need some assistance. Then, you know, we are just shooting in the dark.
I wanted to ask this question to all of you, but maybe let's start with you, Elena. We were talking about all the difficulties, and what I've seen and heard from all you and other people that I've interviewed is that organizations here in Texas have to get really creative to get funding and to create new programs and to kind of break these silos. How have you experienced that attitude? How, in your case, in your organization, you get creative and find ways to find funds and to get stuff done?
Well, the really complex problems that we're all trying to solve require multi-sector and multi-agency collaboration, and funding streams tend to be, we'll pay $10 for this, and then somebody over here will pay $10 for that, and that keeps everybody in their silos. There are mechanisms that are newly developing, and actually we have an example in Austin of ways to finance solutions to these complex problems. And I'll give you an example of a project we're involved in Austin having to do with chronic homelessness. And it's structured as a pay-for-success project. And what that means is that there are investors who pay on the front end for programmatic solutions that, if successful, on the back end, the various agencies who benefit from it repay the investors. And in this particular program, we have the City of Austin, who is interested in paying for outcomes related to days housed. We have Travis County that is interested in reducing criminal justice encounters where people shouldn't be in the justice system in the first place. And we have healthcare payers, and we're part of that group, who are interested in reducing inappropriate and unnecessary hospitalizations and emergency room visits. And together, we will repay investors if this entire wraparound housing program works. And the beauty of that is that each of these sectors has a different interest in solving a problem, and if we can come together through a mechanism like Pay for Success or Social Impact Bond is another name for the same kind of program, then we can do something like that, and you can actually allocate the costs. There are other models like that. We're working on one in Waco that actually conceives of health as a public good and uses an auction or bidding process to allocate the costs of a public good to various sectors. And that's the way that you get sectors to come together and not say, well, I'm not going to pay for this because someone else is going to benefit for it, by bringing them all together to share the costs and share the benefits of those problems. And we can do that. There's legislation in the state that was passed, I think 3 sessions ago now, that allows pay-for-success programs by state agencies, and we need to use that.
And one of the interesting things of the pay-for-success model is actually it's kind of friendly with both sides of the aisle in a way, because since it lowers the risks for the public investment, conservatively fiscal people should kind of promote it, right?
Yes, in theory. It takes all of the risk of failure away from the public entities. They only pay if the project actually succeeds in meeting outcomes. And the idea is that if it succeeds in meeting outcomes and you've proven it on someone else's dime, then you institutionalize it because you know that in the long run it improves outcomes and reduces your costs.
So in theory, and why are we not seeing it more?
Well, that's an excellent question. I think it takes creativity and leadership, and we have seen some of that in Austin because the city and the county got together there and said, let's look at a way to solve this problem holistically.
Dr. Sharma, you're involved in several projects related to food insecurity. How do you, in your case, have gotten to get creative and try to find funds anywhere? How do you do that?
Yeah, great question. And, I want to echo what Elena just said, that what's important is what is the problem that we want to solve, right? I think sometimes when the organizations that are looking for funding or applying for funding, when you're trying to, approach funding from a perspective of a project rather than what is the problem you're trying to solve, immediately it creates an ecosystem of competition rather than collaboration, because now you have multiple people competing and applying for funding and proposals to solve, for whatever it is that they want to do. Instead, if we start with what is the problem we want to solve, and then who are the right people at the table that are best positioned to solve those issues, I think that creates a sense of collaboration. And I'll give you an example with something that I worked on for several years now, since 2012, which evolved and became its own nonprofit called Brighter Bites, where we wanted to solve this issue of food insecurity and childhood obesity among low-income families, because it coexists, right? There's this interesting paradox among families who are under-resourced, that they're struggling with chronic conditions and with issues like food insecurity at the same time. And so what we did was we wanted to link that with food systems issues, which is food waste in America. So in America, we waste 30% of what we grow in terms of fruits and vegetables. That's about 40 billion pounds of fresh produce that doesn't even make it to the grocery store. So, and we don't even see it, right? It's an issue that's kind of well hidden. So we said, okay, how do we link these in a way that we can reduce food waste and link it to public health impact? So that's kind of what we've done with Brighter Bites, where we bring in as much reclaimed produce as we possibly can, and we didn't want to reinvent the wheel, so we linked it to the local food banks, working with local food banks, and then channeling that produce in a very organized, systematic way into the hands of families that need it the most, and combine that with education so that they know what to do with it. Fresh food insecurity is not just about food when it comes to health, right? You're talking about eating well to live well. And to do that, we need to get the right healthy food into the hands of the families, but we have to teach them how to use it. So how do you create, again, that ecosystem where we've leveraged schools, where we implement the program, we've leveraged the food banks that are experts in doing the food distribution systems, and we've leveraged the for-profit industry, including the retail, food distribution, all the way up to the growers. So we can do it, we can link existing systems to then address the solutions for the families who are most in need. So that's one example. And then another, which is kind of a different approach, where we are specifically working on social determinants of health in bringing together the healthcare industry and the nonprofit industry in Harris County to really focus around addressing these health issues. So it's a Greater Houston Coalition on Social Determinants of Health, where we have over 100 organizations right now that are invested and already working in this space. And I think that's an important takeaway for us here. There's a lot of momentum and interest in moving in this direction, but how do we organize ourselves together to address the problem at hand? Yeah.
I wanted to also mention that there are other factors also into food insecurity that play out, like time. Something as simple as having a shorter commute can allow you to have 5, 10, 30 extra minutes and actually cook instead of going to the Whataburger. And maybe ended up having like a better food quality, a salad instead of some fries. This is a question for both of you, Mr. Williams and Representative. Are leaders connecting those dots, like for example, of how transit impacts health and other factors can impact health and quality of life in general?
We're doing a lot in the area of transportation. Mm-hmm. We just passed right in the city of Houston, we just passed a big transportation initiative, metro initiative, because if you don't have the transportation to get somewhere, particularly, and it has to be close, it's meaningless to be able to provide a whole lot of things for people. The state of Texas has been, for the last several years, doing a lot in the area of transportation. And we recognize that is really critical in every aspect of our lives.
Mr. Williams, I don't know if you want to add something about that.
I think at an intellectual level that people understand it. I think that from a practical standpoint, you have to get the leadership to really come up with long-term plans to deal with that. And oftentimes, it has to be done in segments or phases in order for it to be effective. I think Houston is a perfect example of that. We have, one of our programs require that we go throughout the community looking for case contacts for people, say, with TB. If for us, even though we have like 4 locations, we used to have 7, it will take a day or to just go to Acres Home and then go to Sunnyside in order to bring that patient in. And so I think that, you know, a lot of progress has been made, but we have to figure out other solutions to help, you know, to expedite, in this case, access to treatment for a real specialized population.
Well, one thing I want to compliment you on, you have what is called the stroke unit. And that's a unit that's kind of circulates throughout the city of Houston or Harris County for persons with strokes, and they can get to them quickly. And this is a mobile unit. And we might be envisioning in the future a lot of more mobile things. We have an emergency response for a person with mental illness, because sometimes there are persons you see directing traffic who are not law enforcement, but they may be having a mental episode, and these response teams comes to that site with psychologists, psychiatrists, and they can access that person's medical record if they're in the system and have been receiving psychotropic medication for their particular situation, and they can treat them there without having to take them to jail or to a hospital, unless those things are necessary. So that we're making some great inroads.
You spoke about medical records, and data is becoming such a relevant part of the conversation in all levels of public policy. And in health, you have so many actors playing at the same time that I assume that can be a challenge to kind of share that information and actually get better results and outcomes that are based in data and evidence. Is that an issue, and how are you solving that?
We addressed that issue in the legislature last session when the city of Houston was asking for a legislation to be passed so that agencies that work with these groups of individuals will be able to share necessary data. We're trying to solve those problems. We recognize privacy is significant, it's very important, and we definitely don't want to do anything to encroach upon the privacy, but we are being able to allow agencies and departments to be able to share information so that they can be able to have to better serve the public.
And I can just add to that there is a lot of appetite among the healthcare partners to really understand how these they're investing in these issues of social determinants of health themselves. You know, for example, Harris Health has food pharmacies in their Strawberry Health Clinic right now. So they're investing heavily into these issues, and they want to determine how it's impacting their patients. So while, you know, there's still things that need to be ironed out in terms of data sharing, there is appetite to really understand how these investments are making an impact on their patient and what is the return of these investments that they're making.
Mr. Williams, do you have feelings about this?
I have some thoughts. Actually, the representative was absolutely correct. There was legislation that was passed that made it easier for us to share data, particularly amongst local health departments, and we're really grateful for that because we struggled for several years trying to get access to data that we actually produce.
I wanted to do a last question before we go to the Q&A. So if you have questions, get ready. Maybe start walking closer to the microphones, and maybe each one of you can answer briefly from your perspective. We are in a day talking about cities, and one of the things that we're seeing in our 4 or 5 biggest cities is important demographic changes in the core of our cities that are getting much more valued than they were 10 years ago, when seeing displacement, gentrification, whichever way you want to put it, and we are also started seeing suburbanization of poverty. And I wanted to ask you, how do you see this issue affecting health outcomes in each one of your areas?
So I'll go back to data. We have data at a fairly granular level within Harris County that can tell you by community, by zip code, sometimes by block level, what the various indicators are for different populations, different geographies. And we sometimes have a tendency to look at data at a county level and say, here's where this number is, and so here's what we should do. Because we have this granular data, we are able to identify problems and then direct solutions to pinpoint them where they are. And what that means is that it doesn't matter if you live in a suburbanized part of the county as opposed to in the city core. You may have the same set of problems, but if we can identify that by geography, then we know where to do the work, as opposed to trying to do something across the whole county and hope you get to the right people. And so I don't see, the fact that people in poverty are moving around, it's the same problem. We just have to find them and work where those people are.
And just, what's interesting in food insecurity, we found that when we layered on some of the food insecurity screening data from the healthcare systems onto the food desert or the lower income, we found that actually food insecurity in Harris County, the people are residing everywhere. They're not just residing in food desert areas. So I think when thinking about that, data is important. It's a critical piece of trying to understand where the need is, and sometimes that the need doesn't coalesce, with what we might think the landscape is. So this whole, notion of food deserts and thinking that food insecurity just resides in the food deserts is actually false for Harris County. Those two don't match.
Mm-hmm. Mr. Williams.
I think that what they're saying is important because we have to include people that reside in those various communities and neighborhoods and coming up with the solutions. And so I think trying to do something from a countywide perspective is not going to be as effective.
So if you have any questions, please feel free to come to the microphones. We have one here and another here in the right.
Hi, my name is Anna Nunez. First of all, I love your socks. Can we talk about the recent efforts for the public charge, where families that are legalized Latino, or not just Latino immigrants, but immigrants who are trying to legalize properly through the process would have been penalized if they would use any kind of health benefit. I know U.S. citizens who are trying to legalize their families and are not using the public health benefits. We have immigrants who are legal, who are withdrawing from WIC, and all of these benefits that they qualify for, and that's a big public health crisis. When SNAP and kids are going hungry because of immigrants are fearing. We have over 6 million children who belong to mixed status families, so it's not just an us or them situation, it's an our situation. Thank you.
Mr. Williams,
Of course I'm going to
we
comment
were
on
talking
that one.
first you've seen in the data changes,
Yes.
have you?
Well, I'll give you an example. Our WIC program, Women's, Infants, and Children program, at its highest point had over 80,000 families enrolled in it. Right now, it is about in the middle to the low 50s, and that is an example of individuals who are really fearful of accessing services. And this has been the experience across the country. We have been trying to work with a variety of groups doing outreach from a public health standpoint. I'm in our department. I sent a letter out to all of our partners telling people that we were still open for business, and it didn't matter. We still wanted people to come to us. So it's an ongoing challenge, and I think that we all have to get involved in that, and also maybe utilize groups that are grassroots groups that are connected to communities like TOPS, Texans Together, to help us continue to spread that word.
Representative, have you seen also in your district, when you talk with your constituency, this issue too, more fear of reaching out to getting services?
Absolutely. All across my district where they live. And I'm hopeful that the information is going to be received by them where they can come and really access those services and not be fearful of getting them.
And I assume that there's like a higher need for being, again, creative and really going and looking for that people, that community that it's basically hiding. How do we do that? Do we have any good experiences in that sense?
So what I'm seeing, particularly as a funder, and we fund a lot of the organizations that work with these populations, they want to bring people in, and people are really afraid. And what we're hearing is, well, charity will have to step in. And charity cannot take the place of government. We are here to assist with public policy, to take risks, to experiment, and to try to get new stuff going, but we cannot take the place of SNAP or WIC. And what we are trying to do is turn it back so that we do get the public policy that we need. One of the organizations in Houston that is doing a lot of really good work in this area is the Houston Immigration Legal Services Collaborative. And what we're hoping they're going to be able to do is get accurate information to families. There's a lot of misinformation, and so people are staying away out of fear, but if the fear is based on misinformation, there's an opportunity through the organizations that they trust to correct that misinformation. But as long as this fear goes on, we are going to continue to see people drop off the rolls, and that includes off Medicaid, where we have kids who are entitled to be insured by Medicaid and CHIP, and their parents are withdrawing them.
So this is pretty like something that we see across the board. Do we see this fear too when you're working with food insecurity issues, or not so much? Does this impact it?
100%. I mean, the people, when our pregnant women and women with infants don't participate in WIC, clearly you're going to, one of the biggest costs are associated with preterm birth. And so, WIC services can help prevent and help maintain good prenatal care for the mother during pregnancy. And so when these women, we know from some of our data that the women are, the women who are uninsured access healthcare, prenatal care later on. And then you're going to then see them and their child in the NICU after, because of birth-related complications, which are tremendous, and on an already overburdened healthcare system, right? So it trickles down in addition to now having poor outcomes for the child and the mother, it also trickles down to the taxpayers ultimately who have to then pay for it.
Good morning. I'm familiar with most of you there, and as a school board trustee in the Acres Home area, we get to see the impact of what it does to the children in what I call food deserts and healthcare deserts. Speaking of silos, my question is this: we've got the city, we've got a county representative in the form of Harris Health, and we have the state here. There are a lot of times that you act as if you are in silos. What are you doing to work together to help solve some of these problems?
Well, Paul, one of the things that we're doing, we're trying to work closer together, and to be able to, we're reaching across the governmental, I should say, aisle, government, cities, counties, to be able to come together to do those things that we can do to kind of solve these problems. Since there has been such a separation, it's just not going to happen overnight that we're just going to be able to, close the gaps in these things, but we're trying to close the gaps. We recognize many of them, and we're trying to do the best we can to close them as fast as we possibly can without jeopardizing quality of services and overlooking services that may be needed.
I can give you two examples of where I think we have great collaboration between the city and the county in various departments. Both of them are under our My Brother's Keeper efforts. One has to do with wraparound services that we're providing in various middle schools within the Houston Independent School District. Instead of our department, as a health department, actually hiring staff to provide social workers or caseworkers in schools, we really lean on the Protective Services Department and their KAIS programs. They were able to provide a couple of positions on their dime, and we added to their dime to add additional positions to create wraparound services in a couple of school feeder patterns. We even developed a early warning system that was created by Harris Center, Protective Services, communities in schools, and my department. And they're using those tools. Certainly, they're not university accessible through the whole school district, but they are used in the schools that we're piloting these particular initiatives. Another example of where we have worked with Protective Services, the Juvenile Services, and in this case, Commissioner Ellis's office, down in Attucks Middle School and HISD, they were actually arresting, I think last year they had arrested about 48 kids. And so we created a diversion program, which is the first in the country, called Youth Lead. And instead of the school police arresting the kids, they actually refer them to our program. And instead, at this point, instead of having arrested 48 kids, they've only arrested 3 kids this year. And and we're providing wraparound services instead of going to, getting locked up. They're actually doing the assessment that you talked about to figure out what's going on with the kids. These are just examples, I think, of things that we're doing, but the system really has to adopt these strategies if they want to make a difference.
Just as a follow-up on that, and this is maybe for Representative Thompson, Speaker Bonin is a big anti-local control person. It appears to be. Should this be handled at our level, at the city, the county level, or does the state take a bigger role into this? And that's all I have. Thanks.
I think those areas where the state can work well and effective with the local government, we are going to continue to do those things.
Mr.
First, I'd be neglect to say the person that probably did the most for public health for Texans last session was Chair Senfronia Thompson of Public Health. So thank you. And I would also be neglect if I didn't work with Stephen Williams and bring up this for Elena Marks on it. So many people do not know about the 1115 waivers expiring and the disproportionate amount of services on both behavioral health and public health programs like we have at the City of Houston. Would you care to talk about how that expiration is going to either lead to a lot of needed innovation at the local level or a lot of gaps that Chair Thompson is going to have to address next legislative session?
Ooh, well, that's a tough one. When I think about the 1115 waiver is a program within Medicaid whereby the federal government is putting billions of dollars into our local systems across the state every year. And that program is going to expire. It was set to expire a while ago. It was put in place originally when we were expecting there to be Medicaid expansion that was mandatory, and it was set up to prepare local systems to take in and be ready to serve an influx of new patients. Well, that didn't happen. And so the federal government, under both President Obama and President Trump, have said, enough of this. You're supposed to have a system, and we have Medicaid and Medicaid expansion as a mechanism for doing this. And so as the waiver begins to expire, many of these really innovative, very on-the-ground programs will simply go away. There is not another source of funding for them. And the concern I have is whether the state will be able to put forth a plan that actually gains approval at the federal government. They don't want to do a Medicaid expansion, which would be the way to institutionalize those dollars and fund the providers to be able to do the work. And the plan documents that have been filed to date are encouraging, but they're very broad and they're not specific enough. And I think we're all concerned as to what is going to happen. And one of the things we have heard from leadership is that they will wait and see. And for those of us on the ground doing the work, it's not okay. Programs will shut down.
What that means for health departments throughout the state is around $135 million a year. For the Houston Health Department, it's about $30 million a year.
I just want to add, as someone who has one of those programs being implemented through UT Physicians, I know that UT Physicians is working to integrate, as someone who has a program, and they're here right now, that's being implemented through UT Physicians, through the 1115 Medicaid waiver. It is something, it's a big part of the conversation that we're having, is how do you then integrate this into the standard of care and into what the UT physician system is already doing. So it's definitely a big part of the conversation, because you don't want to stop those services.
I think we have time for just one more question. So let's keep it short and direct.
First of all, I would like to thank Representative Thompson for her service and the things that she's done that affected my life. Ms. Thompson worked with me on passing 2 bills when Medicare and Medicaid rolled out into the managed care environment in the year 2000. One is the any willing provider rule, meaning when this was happening, a lot of the HMOs had the ability to say, oh, doctor, we got too many OBGYNs in your zip code. We don't need any more. So under the any willing provider rule, they must accept applications from all doctors to be a part of their HMO, and then let the patients decide on who they want. The second rule is Ms. Thompson worked to pass a law that allows a woman, when she becomes pregnant, to do her own referral to her own OBGYN. She doesn't have to call her provider to get a referral. She can just do it herself. So I want to thank you for helping us do that. I used to manage the insurance contracts for 256 doctors. And when you talk about health care, it's 2 words that always come up: affordability and accessibility. But what you never bring up is the money, utilization. Because here you've got a big corporation like HMO Blue Texas, Cigna, Aetna, and then you have the hospitals, and then you have the providers. The corporations want utilization because that's how they make money. Use our services. Come in. Let's build a medical plaza over here and fill it with doctors to refer, and give them rent cuts so they'll pump patients through our hospital. But here's the problem. When Ms. Thompson and I were little kids, we had doctors in our neighborhood. We had accessibility to doctors. And so when we went to see that family doctor, that neighborhood provider, he knew our parents. He knew what to look for.
Mr. Sorry to interrupt, but since we're running out of time, what's the question?
Well, where I'm going with this is, why is it you all don't look at the way money flows from these corporations and the doctors, and how these big clinics are popping up in the neighborhoods, and they don't even ask a neighborhood doctor, would you like to be a part of the clinic? They put the clinic there and fill it full of medical students, okay? And so the patients are the ones that suffer, because here's a mother with a kid or 2 kids, she's got to get on a hot bus and ride all the way to the medical center and transfer maybe 2 or 3 times. Is that accessibility? You know, and so she defers to put that off as long as possible, and then ends up in ER. So we need more localization of providers where they're accessible. But in order to do that, you're going to have to look at the money and the way the money flows, because on the other side of the coin, they don't want the doctors to use services. They limit them. They give them a cap, say we're going to pay you $27.50 per patient per month, and you've got to manage that with each person.
Okay, let's give our speaker some time to answer the question. I don't know if Elena, you want to go.
So I think you're dead on with follow the money. People and organizations do what they're paid to do. We have a system in this country that overly incents high dollar, high cost health care. We have said as a country we want that. We're wrong. We've got to change what we say we want. But if we incent payers, and that's Medicare and Medicaid as the two largest ones, to pay providers for actually producing health outcomes, they'll do that. But right now, we are saying that we will pay you more if you can do a C-section. We will pay you more if you put people in the NICU. And as long as that is the incentive, that's what people are going to do. If we said we will pay you to reduce asthma exacerbations, they'd be doing home repair and they wouldn't be paying to go to the emergency room over and over again. So you're right on with follow the money. It's the incentives.
I want to thank you so much, Elena Marks, Representative Senfronia Thompson, Dr. Shreela Sharma, and Mr. Stephen Williams for being here. Let's give them another round of applause, please.